Hello everyone, and thank you for your interest in watching this webinar on sleep and drug abuse, sponsored by the Pipeline Development Committee of the Sleep Research Society. My name is Lais F, and I am coordinating this webinar. The goal of this webinar is to give you a broad understanding of the relationship between sleep and drug abuse, from the effects of drugs of abuse on sleep to the consequences of sleep-wake disturbances on the drug abuse cycle, including potential mechanisms underlying this relationship. During this first lecture, I will be giving you an overview of sleep and drug abuse. Dr. Timothy Roehrs will then provide you with further details on sleep disturbances in drug abuse. Dr. Monica Anderson will follow with an in-depth look into the effects of sleep-wake manipulations on the abuse-related behavioral effects of drugs of abuse. And finally, Dr. Stephanie Borgland will dive into the description of orexin neurotransmission as a potential mechanism explaining the relationship between sleep and drug abuse. During my talk, I will be giving you a broad overview of the field on sleep and drug abuse. Starting with the definition of drug abuse itself. I believe most of you who will be watching this webinar are sleep experts, so I will take some time here to explain drug abuse in more details. Drug addiction is commonly defined as a chronic relapsing disorder characterized by loss of control over drug intake despite several negative consequences of drug use. In the United States, the prevalence of drug use in the lifetime in adults continues to be remarkably high, with 80% of the population reporting having used alcohol and 55.7% reporting having used cigarette in the lifetime. Alarmingly, 49.2% of the population also reports having used illicit drugs. Drug abuse poses several socioeconomic and legal challenges to society, as well as physical, behavioral, and mental health outcomes to the individual. And despite many years of research and several medications approved for the treatment of substance use disorder, relapse rates remain extremely high. Therefore, research aimed at understanding the factors that can influence the course of drug addiction, particularly the risk for relapse, is of utmost importance. And the first key concept when studying drug abuse is understanding that drug addiction is a brain disease. As Dr. Alan Lashner wrote back in 1997, understanding addiction as a brain disease explains in part why historic policy strategies focusing solely on the social and criminal justice aspects of drug use and addiction have been unsuccessful. If the brain is the core of the problem, attending to the brain needs to be a core part of the solution. Since then, significant progress has been made in the field, from the understanding of neural pathways underlying drug abuse to an objective set of diagnostic criteria established by the Diagnostic and Statistical Manual of Mental Disorders. According to the DSM-5, drug addiction is defined as a group of cognitive, behavioral, and physiologic symptoms that indicate the continuous use of a substance despite several problems associated with it. The severity of the disease, from mild to severe, can be established based on a series of symptoms. Symptomatic criteria include taking the substance in larger amounts or over a longer period than was originally intended, unsuccessful efforts to decrease or discontinue use despite desire to cut down or regulate use, spending a large time obtaining the substance, using the substance, or recovering from its effects, or craving, which is an intense desire or urge for the drug. Social impairment criteria include failure to fulfill major role obligations at work, school, or home, continuing substance use despite having persistent or recurrent social or interpersonal problems, or reducing important social, occupational, or recreational activities. Risky use criteria include recurrent substance use in situations in which it is physically hazardous, and continuing substance use despite knowledge of having a persistent or recurrent physical or psychological problem. Finally, pharmacological criteria include tolerance and withdrawal, and the DSM-5 also brings sleep impairment as a common symptom reported during withdrawal, bringing to light the importance of sleep management in this population. Several aspects of substance use disorders have prompted researchers to investigate relationships between sleep and drug addiction. First, many drugs with abuse potential are taken and/or prescribed in the context of sleep-wake disorders. Examples are stimulant drugs prescribed for hypersomnia or narcolepsy, or even benzodiazepines prescribed for insomnia or behavioral sleep disorders. Also, it's important to emphasize that individuals using psychostimulant substances show a progressively growing nocturnal patterns of drug use because it's been more and more common to skip one-night sleep because of job or academic demands, and psychostimulants are frequently used when irregular work-rest patterns cause excessive sleepiness due to their activity as alertness-enhancing drugs. And among young adults, late-night parties are often associated with the use of recreational drugs of abuse, which continues to expand markedly in this population. Individuals also frequently report using depressant drugs of abuse, such as alcohol or benzodiazepines, in combination of stimulant drugs, such as cocaine and amphetamines, to come down from the high after a night of partying. Most, if not all, drugs of abuse acutely alter sleep architecture and/or induce other sleep disorders, such as opioid-induced sleep disordered breathing. Sleep loss has also been shown to amplify the reactivity of brain reward circuits in response to pleasurable stimuli in humans, associated with higher connectivity in primary pathways of visual processing and extensions to limbic regions. These neural changes are followed by an enhanced number of emotional stimuli judged as pleasurable after periods of sleep deprivation. Together, these and other findings indicate that the relationship between sleep and drug abuse is bidirectional. Individuals with substance use disorders show a high prevalence of sleep problems, and sleep disruption also may affect the course of drug addiction. Regarding the effects of drugs of abuse on sleep, a study from 2009 showed that sleep disorders are very common among substance abusers. In this study, 96.6% of the individuals showed a PSQI score above 5, with 16.6% and 40% qualifying for severe and moderate insomnia, respectively. A large percentage of these individuals also subjectively reported having other sleep disorders, such as sleep apnea and restless leg syndrome. And depression was also very highly prevalent in this population. On the other side of the cycle, studies have also shown that individuals with a history of sleep problems are at higher risk for the development of substance use disorders. In a study from 1989, Ford and Kamarov did a follow-up study with 7,954 respondents about sleep complaints and psychiatric symptoms. They found that 10.2% and 3.2% of the patients reported insomnia and hypersomnia, respectively, at the first interview. 40% of these with insomnia and 46.5% of those with hypersomnia had a psychiatric disorder, compared to only 16.4% of those with no sleep complaints. As highlighted on this table, the risk of developing alcohol abuse and drug abuse was significantly higher in those who had insomnia at the first interview compared with those without insomnia. A study from 2010 by Wong and colleagues also investigated whether childhood sleep problems could predict alcohol and drug outcomes in young adulthood. The authors find that overtiredness during childhood significantly predicted alcohol use outcomes and alcohol-related problems in young adults, and also trouble sleeping at ages 12 to 17 predicted drug-related problems in young adults. These findings further emphasize that having a history of insufficient sleep or a sleep impairment can increase the risk for drug use and abuse. Studies have suggested that individuals with sleep disturbances are also more likely to relapse during treatment, particularly those with alcohol use disorders. According to a theory review published by Brower and Perron, persons who are recovering from an addiction to any psychoactive substance and have a sleep disturbance are at an increased risk of relapse compared to those without a sleep disturbance. Therefore, relapse becomes an important contributor to this cycle involving drug use and sleep impairment, and seems to be the engine that keeps the system in motion. Although this cycle seems to be in place for all drugs of abuse, it is particularly complex and problematic in the context of opioid use and abuse. When opioid is the drug being illustrated in the cycle, in addition to changes in sleep architecture, sleep disordered breathing also contributes to the sleep impairment observed in opioid users, which could also influence relapse. Also, pain is another important factor that influences not only opioid intake, but also sleep quality and relapse into opioid use. Therefore, the complexity of the opioid abuse and sleep impairment cycle could further explain the dimension of the opioid use problem in the United States, which is currently being considered an epidemic with more than 130 people dying of an opioid overdose every day. These studies further elucidate the feed-forward framework observed with drug abuse and sleep impairment. So in the subsequent lectures, Dr. Timothy Roehrs will dive deeper into the sleep disturbances observed in drug abuse, and Dr. Monica Anderson will further explore with you the effects of sleep-wake manipulations on the abuse-related behavioral effects of drugs of abuse. Given this strong interaction between sleep and drug abuse, recent research has focused on the understanding of neuromechanisms underlying this relationship. In order to understand potential common mechanisms, I will first briefly go over the pathways involved in drug abuse and in sleep separately. Decades of research have demonstrated that most drugs of abuse modulate the activity of dopaminergic pathways in the mesolimbic system. So this figure shows the structures of the brain involved in addiction, with the nucleus accumbens being the main structure involved in the rewarding effects of drugs of abuse and natural stimuli, and is thought to be the important in assessing reward and how specific things can stand out from all others, which is a property called saliency. The main region projecting into the nucleus accumbens is the ventral tegmental area. That innervation going from the ventral tegmental area to the nucleus accumbens is a dopaminergic innervation, and that is the dopamine pathway through which drugs of abuse lead to increased levels of dopamine in the nucleus accumbens. You also have other regions such as the orbitofrontal cortex, which is involved in decision-making and determining the expected rewards and punishments of an action. The amygdala and hippocampus are involved in forming memories of the stimulus or reward relationship and are very important for the formation of drug environment conditioning. Finally, inhibitory control and emotional regulation are provided by the prefrontal cortex and the anterior cingulate gyrus. So these are like the filters of our brain. Now keep this image in mind and we will fade into another very similar image, but that illustrates the main brain regions involved in sleep-wake regulation instead. Our brain is maintained awake by two main systems called the ascending arousal systems. A cholinergic system in orange in the figure, which is comprised of neurons in the upper pons that produce acetylcholine, which activates areas of the thalamus responsible for channeling signals to the cerebral cortex, which is the site of consciousness. And also a monoaminergic system depicted in the figure in blue, comprised of neurotransmitters including noradrenaline, serotonin, histamine, and dopamine that are produced in the pons, hypothalamus, and other nearby regions and prime the cerebral cortex to receive signals from the thalamus. When the brain is ready to go to sleep, which is regulated by homeostatic and circadian controls, the main sleep center in the brain, the ventrolateral preoptic nucleus, or VLPO in purple, which would be number 4 in the figure, is activated. The VLPO releases GABA, the main CNS inhibitory neuron, and that binds to receptors in the hypothalamus and in the pons to inhibit the ascending arousal system. So when it's time to wake up, the ascending arousal systems are activated again and inhibit the sleep or VLPO system. So the interaction and flow between wake and sleep neurotransmitter switches our brains between sleep and wakefulness in very carefully regulated cycles. Now, if you overlap the brain image illustrating the reward pathways and the brain image illustrating the sleep-wake pathways, you can see how many of the brain regions involved in sleep overlap with those involved in drug addiction, which further illustrates why these two phenomena are so interconnected. Several different neurotransmitter systems have been implicated in the sleep-related effects of drugs of abuse, as you can see in this table. For instance, drugs of abuse increase the levels of monoamines such as norepinephrine, serotonin, and dopamine, and these effects have been suggested to be involved in the wake-promoting or sleep-disrupting effects of drugs of abuse. However, the mechanisms underlying the effects of drugs of abuse on sleep and vice versa still haven't been completely understood. And more recent research has focused on a very specific system in this investigation. The orexin or hypocretin system. This is a critical regulator of both reward and sleep-wake processes. Although orexin is exclusively produced in the lateral hypothalamic area, orexin neurons innervate many brain regions and are involved in several different processes. Orexin cells only fire during waking, and they are silent during sleep. So the orexin system is unique in being essential for sustaining the waking state. For example, its disruption in patients with narcolepsy causes the periodic and abrupt interruptions of the conscious state, and the cluster of orexin neurons in the hypothalamus is a node that links to other arousal-related nuclei, including the basal forebrain cholinergic neurons, dorsal raphe nucleus serotonin neurons, ventral tegmental area dopamine neurons, lateral dorsal tegmental cholinergic neurons, and locus coeruleus norepinephrine neurons. So it is well positioned in a way that it orchestrates a synchronous activation of multiple arousal systems. In addition to its role in arousal, orexin also has a role in the rewarding effects of drugs of abuse. Orexin neurons are activated by reward and project to the dopamine neurons in the ventral tegmental area that innervate the nucleus accumbens and mediate reward, and they can also influence the nucleus accumbens via their direct projections to it as well. Studies have shown that chronic exposure to drugs of abuse increases the number of orexin neurons, which would be expected to create a state of hyperarousal and may underlie the insomnia observed in drug users. So it has also been suggested that the orexin is specifically engaged in substance abuse during elevated motivational states, such as when the effort to obtain the drug is high or when the animals are stressed. So orexin systems may be particularly active during relapse, and this would be consistent with a state of increased arousal that follows craving. Orexin binds to two different receptors called orexin 1 and orexin 2 receptors. A growing body of evidence indicates that orexin 1 receptors are involved in reward and addiction, while orexin 2 receptors are involved in sleep-wake regulation. Therefore, there has been an increasing interest in the use of dual orexin receptor antagonists, or DORAs, which are non-selective orexin antagonists, as these agents may provide a twofold benefit for preventing two distinct but interrelated effects of orexin, the potentiation of reward and arousal effects, which could help attenuate drug reward and improve sleep disturbances. DORAs have been proposed as a treatment for sleep disorders and also for substance use disorders. And also recent data show that DORAs improved actigraphy-based sleep measures in individuals with cocaine use disorder. And we have also shown that a DORA improved sleep measures in methamphetamine-treated rhesus monkeys. So during our final lecture, Dr. Stephanie Borgland will further detail the orexin mechanisms regulating sleep and reward. In summary, while exposure to drugs of abuse is causal to sleep dysfunctions that further promote chronic use, sleep disorders in turn are risk factors for substance abuse, and their severity can predict the prognosis of substance use disorders. There is a striking interconnection between the neurobiology of sleep and substance use disorders that explains why these two phenomena are so related, with individuals with substance use disorders showing sleep disturbances in all phases of addiction and sleep impairment potentiating the abuse-related behavioral effects of drugs of abuse, including increasing the risk for relapse. So I hope you enjoyed the subsequent lectures, which will take a deeper dive into the aspects that I approached in my talk. Although it is becoming well accepted that there are neurobiological links between sleep dysfunction and substance abuse behavior that result in comorbidity, Research in this field is still in its very early stages, so we need a next generation of researchers who will join us in investigating this extremely interesting relationship with such important and dire consequences. Thank you.
Hello, I'm Tim Roehrs, Senior Bioscientist at the Sleep Disorders and Research Center at Henry Ford Health System and Professor of Psychiatry and Behavioral Neuroscience at the School of Medicine, Wayne State University. I would like to present the topic Sleep and Substance Use Disorders, a Bidirectional Relationship. This is a slight adjustment in my topic as advertised, and the reason for the change is that there have been any number of reviews on the effects of drugs of abuse on sleep, but emerging data suggests that sleep alertness disturbance has an important role in substance use disorder, and so I will argue that this relation is bidirectional. Here I disclose my potential conflicts. I'm funded by the National Institute of Drug Abuse, Merck Pharmaceuticals, and the National Heart, Lung, and Blood Institute. These potential conflicts will not have any effect on the material that I will be discussing with you. These are my objectives for this talk. I would like to review the diagnostic criteria in sleep medicine and psychiatry as they relate to sleep and substance use. This gives us a perspective on the current understanding of the role of sleep and substance use disorder. Next, I will make an important distinction particularly relevant to sleep medicine, and that distinction is between drug seeking and therapy seeking. And then finally, I will discuss how sleep alertness disturbance contributes to the addiction cycle, the initiation, maintenance, and relapse. That's the defining characteristic of substance use disorder. So let's start. Diagnostic criteria for sleep alertness disturbance are found in two sources: the International Classification of Sleep Disorders, third edition, and the Diagnostic and Statistical Manual of Mental Disorders, fifth edition. For substance use disorders, it is found in the DSM-5 substance use disorder section. As you see here, the most common sleep alertness disturbance in both ICSD-3 and DSM-5 is insomnia. But note that there is no recognition that sleep disturbance can lead to alertness disturbance, which then could also contribute to substance use disorder. In DSM-5, insomnia is classified as comorbid with substance use disorder if it occurs beyond the immediate use of the substance. In ICSD-3, a subtype of insomnia is identified called insomnia due to drugs or substances. And I would suggest that the ICSD is making a somewhat stronger causal inference regarding the association. Now, as regards sleep-wake in DSM-5 substance use disorder section, most drugs of abuse are disruptive of sleep and or daytime alertness, but those are not major criteria for substance use disorder, despite the fact that emerging data suggests sleep disturbance is a major predictor of relapse. Sleep alertness disturbance are only mentioned as possible symptoms of withdrawal syndromes, and these symptoms of tolerance and withdrawal are not treated as substance use disorder when they occur in the context of medical treatment. Now, let's look at sleep alertness disturbance and the initiation of substance use disorder. The investigator can take two approaches. One is to do prospective studies that identify at time one a sleep alertness disorder and then determine whether that sleep alertness disorder has evolved into a substance use disorder at time two. This kind of research requires large samples, and in the very few such studies of this order, the data are self-report only. Now, a second approach, which is the approach I have taken, is to identify in laboratory studies physiologic and behavioral markers that are suggestive of a heightened risk for the development of a substance use disorder. Now, I made reference to the importance of distinguishing therapy seeking from drug seeking, and that sometimes shifts in the context of therapeutic use of a drug. It occurs when tolerance develops, doses escalated with physical dependence developing during the period of therapy use, and then the non-therapeutic effects of the drug, its euphorogenic and rewarding effects are discovered during the period of therapeutic use, often referred to in the drug abuse literature as accidental dependence. And the distinction is that in drug seeking, the non-disease effects of the drugs are the focus of the behavior, while in therapy seeking, disease or symptom reversal is the focus of the behavior. Now, let me describe a series of studies done at my lab around the risk of the use of alcohol as a sleep aid by people with insomnia. In this series of studies, we studied people with DSM-4R insomnia, the current diagnostic methods at this time, and we studied people who had insomnia according to those diagnostic criteria with the additional requirement that they displayed nocturnal sleep disturbance as well, defined as a sleep efficiency less than 85%. They were also required to have no use of alcohol use disorder or depression. They were moderate social drinkers, and they did not admit to previous use of alcohol as a sleep aid. What we do in these studies was to offer alcohol or placebo beverages administered in color-coded cups. The color-coded cups are administered on separate sampling nights, and then choice nights are given, and the participant can choose the preferred cup based on color. Here you see, relative to age-matched healthy normals, the insomniacs chose active drug, that is ethanol beverage, relative to placebo on more nights in yellow, and more subjects chose the ethanol relative to normals who actually preferred placebo. Additionally, the insomniacs took more alcohol refills. This is administration before sleep, and that's very different than what we saw in the normals who actually preferred placebo. But alcohol improved the slow wave sleep of those people with insomnia. Here you see the minutes are the percent of stage 3-4 sleep under placebo versus with this 0.5 gram per kilogram dose. That's about 4 drinks. And the alcohol increased slow wave sleep relative to the normals. In essence, it normalized their slow wave sleep. We didn't expect an impact in the healthy normals, and at this dose, it did not increase slow wave sleep. The previous studies have been done with much higher doses. And at this dose, alcohol did not reduce slow wave, our total sleep time. This is sleep efficiency, and sleep efficiency in the insomniacs compared on ethanol compared to placebo. But there is a group effect. They differed from normals in their sleep efficiency. Remember, though, that they were chosen for a low sleep efficiency, and here you see their sleep efficiency is about 85%. However, tolerance developed to this slow wave sleep effect. Here you see minutes of stage 3-4 sleep at a placebo dose, a 0.3 gram per kilogram dose, about 2 drinks, or a 6.6 milligram dose. You see the dose related improvement in slow wave sleep on night 2. Comparing to placebo, there was an increase with the intermediate dose and a further increase with the higher dose. However, on night 6 in orange, at the high dose, the improvement in slow wave sleep was lost. Now, in ratings in the morning, ratings of the drug effect that they experienced, the alcohol effect they experienced the previous night, they rated being more sleepy on night 2, but that effect declined by night 6. And on the other hand, their drug liking ratings increased from night 2 to night 6. So what we did in this study was we tried to determine the functional effect of the use of alcohol as a sleep aid. And we randomized insomniacs to either 6 nights of placebo pretreatment versus 6 nights of alcohol pretreatment, and then we gave them choice nights. And on the choice nights, the alcohol pretreated group chose more alcohol refills than the placebo pretreatment group. Presumably, as in that earlier study, tolerance had developed over the 6 nights of pre-exposure, and so higher doses were needed to get the benefit that they previously had experienced. So, I have shown you then that disturbed sleep, specifically a deficiency of slow wave sleep, is a factor that shows behavioral signs, that is, dose escalation, that are suggestive of a risk for alcohol use disorder. Now, another group of drugs with concern around their abuse liability are the benzodiazepine receptor agonists, the hypnotics. And in a series of studies, we used the same self-administration procedures as in the alcohol studies. They were given choice of placebo capsules with one color and active drug capsules with another color. We started these studies with triazolam 0.25 milligrams. It's a clinical dose, and we used a single choice procedure in which on 1 week placebo was the available capsule, and in another week triazolam was the available capsule. And we did this method because that's really the clinical scenario. You're given the prescribed drug that you receive from your physician, and your choice is to take that drug or not take that drug. And in this case, you see in 3 different laboratory studies that the insomniacs chose placebo as frequently as triazolam. We wondered whether this was a laboratory effect, and so we did a home study. And in the home study, again, the same method, single choice method. First of all, overall, they chose at a less frequent rate relative to the lab studies. And secondly, a differentiation between placebo and active drug began to emerge. And as a result, we did a direct choice to determine whether the insomniacs were really able to discriminate between active drug and placebo. And here you see the forced choice data. In other words, on a single night, they could choose either placebo in one color or active drug in another color. Again, emphasizing that this is the clinical dose of triazolam, and in the first choice, they indeed did discriminate. We replicated the single choice in this other condition where placebo and triazolam were chosen as frequently, and there was no differentiation. Now, a discontinuation effect with all of the BZRA agonists is rebound insomnia, and this is sometimes confused to be a withdrawal syndrome, which leads to difficulty stopping benzodiazepine receptor agonist use. Rebound insomnia is worse sleep than at baseline, and here we demonstrate a rebound insomnia. In orange are drug nights, and happens to be night 6, and then on night 7, placebo was substituted. In the placebo group, in the 0.25 milligram, the clinical dose group, our condition, and then in the 0.5 milligram condition. First of all, you see the efficacious effect of the drug comparing placebo with 0.25 milligrams or 0.5 milligrams on minutes of wake during sleep. You also see, though, that there's no improved efficacious effect with the higher doses, but what you do see is rebound insomnia with this higher dose. And the question then is, though, does rebound insomnia enhance self-administration? These are opportunities to choose triazolam 0.5 milligrams on 6 choice nights after an abrupt discontinuation of 0.5, or a tapered discontinuation in which 0.5 was reduced to 0.25 and then to 0.125, or 6 nights of placebo and then a placebo discontinuation. And you see no difference on 6 choice nights of the number chosen in an abrupt versus a tapered discontinuation. So having shown that rebound insomnia did not enhance drug taking, we began to investigate whether multiple nights of use would enhance rebound insomnia. We did a long-term study of 12 months of nightly use of zolbutam at the clinical dose 10 milligrams. And these data relative to a baseline show during a probe in month 1, month 4, and month 12, where we substitute placebo for 2 nights, we show that there is no rebound insomnia across 12 months of nightly use. Rebound would be reflected in a negative score, change score, in terms of sleep efficiency, and all of these change scores are in a positive direction. And we also see that over this long time use, tolerance did not develop. This is total sleep time in month 1 on placebo versus zolpidem. And minutes of total sleep time were increased by 45 minutes in month 1 and 42 minutes in month 8. We also did self-administration probes during the 12 months, and we used the forced choice method. The zolpidem group could choose between placebo or the zolpidem in hatched versus red, or in the placebo group, they could choose two different capsule colors. One was placebo, while the other also was placebo. These are placebo choices in the placebo group across the 12 months, active drug choices across the 12 months as well. And then in the placebo group, however, across the 12 months, we see an escalation of self-administration of placebo. Now, interestingly, we actually had we replicated what we had seen with triazolam versus placebo choices in 2 weeks after 6 nights of triazolam or placebo. And these are the 12-month data I previously showed you. This is month 4 placebo choice versus month 1, and month 12 placebo choice versus month 1. Placebo was escalated in the 2 weeks of triazolam, just like in the 12 months of zolpidem. So we found overall that there's a modest abuse risk with benzodiazepine receptor agonist hypnotics. And in addition to the clear placebo dose escalation, there were also some in the active drug group that dose escalated as well. And so we sought to determine whether sleep-wake predictors for abuse potential could be identified. And we present minutes of wake during sleep plus stage 1 minutes, and as a plotted against the percent of pills chosen, there's a positive relation. The more minutes of wake during sleep, the higher self-administration rates there are. And over here on the left, you see the percent of stage 3-4 sleep, and you see a negative relation. The higher number of pills chosen, percent of pills chosen, occurred in the those with the lower amount of slow wave sleep, very much like our alcohol study. Now, I've shown you then that sleep disturbance could be a risk factor for dose escalation. But remember also that insomnia is a 24-hour disorder. That's the general perception now of insomnia. And insomnia is characterized as a state of hyperarousal, a 24-hour state of hyperarousal, and this has been demonstrated using a number of physiologic measures. We used the MSLT early on, showing that mean daily sleep latency is elevated in insomniacs relative to normals. These are the first data ever shown from Stepansky in '88, elevated MSLT latencies compared to age-matched controls. That was replicated by Bonnet in '95, and it was replicated again by Stepansky in 2000. Now, we wanted to determine what, again, the functional significance of was by doing a study in which we compared nighttime self-administration versus daytime self-administration. We used a forced choice methodology in this early study with triazolam 0.25 milligrams, and these are the number of triazolam choices in yellow versus placebo choices at night, and we replicated what we had previously shown. And these are the number of daytime choices, or the for triazolam versus active drug, and there really wasn't a significant difference. This is not a statistically significant difference, but there were 40% of those who chose triazolam on most of the days. And so we present here the effect of triazolam on the MSLT in the triazolam preferring group versus the placebo preferring group. And these are the placebo effects on MSLT, and that's compared to the triazolam effects. Remember, this is self-administration during the daytime, and you can see, first of all, that the triazolam preferring group had elevated MSLTs relative to the placebo preferring group, and that triazolam 0.25 milligrams during the daytime reduced their MSLT, moderated their MSLT to approximately an average sleep latency of 9 minutes. That didn't differ from the placebo preferring group. Now, interestingly, these laboratory data are very consistent with evidence from case reports regarding reports of benzodiazepine receptor agonist abuse. This is a collection of 53 case reports from '95 to 2002. And notice, first of all, in the case reports, most of the reports indicate that treatment began as treatment for insomnia. But within 3 months, dose had been increased and dramatically, actually, in these case reports. And then additionally, the hypnotic was taken in these documented case reports of benzodiazepine receptor agonist abuse. And this really replicates or is consistent with our laboratory findings. Now let's shift to another drug class, the psychomotor stimulants. They're known for their sleep disruptive effects and their abuse liability, and of course they're used in clinical sleep medicine to improve daytime sleepiness. But they're also abused by high school and college students, and so we instituted a series of studies on the abuse liability of methylphenidate, a psychomotor stimulant not that chemically different from amphetamine itself. And these were studies done in healthy volunteers, and we compare the number of methylphenidate choices relative to placebo choices, again using this color-coded capsule technology. You see the choices after 8 hours of sleep versus 4 hours of sleep, and you see it with a 5, 10, and a 20 milligram dose, and you notice overall there's a main effect of uh, sleep time at night. They chose more frequently, they chose methylphenidate after 4 hours of sleep versus 8 hours of sleep. There were 5 days of choice opportunities given, so a preference would be reflected versus placebo would be reflected in 3 or more choices, and you see overall that methylphenidate is preferred relative to placebo. And as you might expect, 20 milligrams of methylphenidate increases alertness. This is MSLT for 8 hours of sleep and MSLT after 4 hours of sleep. And methylphenidate improves alertness during the daytime. And self-ratings. The alerting effects of methylphenidate were experienced after 4 hours. This is placebo after 4 hours, and they report more fatigue, and that fatigue is reduced by methylphenidate. In the 8-hour condition, there is no difference in fatigue, and there's very low rates of fatigue, as you would expect after 8 hours in bed for healthy normals. Now, the critical and important effect here is the self-ratings of the Addiction Research Center Index. This is the self-rating for the amphetamine scale, which reflects the euphorogenic and rewarding effects of amphetamine. And you'll notice that in the 8-hour condition, 20 milligrams of methylphenidate is relative to placebo is rated as having a more rewarding euphorogenic effects. And notice that in the total sleep deprived condition, that in fact effect is enhanced relative to the enhancement in 8 hours. So, up to this point, I have shown that sleep alertness disturbance may indeed play a role in the development of substance use disorder. I showed that deficiencies in slow wave sleep around alcohol use as a sleep aid, sleep deficiency in slow wave sleep, around benzodiazepine receptor agonists, as well as daytime alertness may show risk. And then in stimulants with methylphenidate, that the appearance of the rewarding and euphorogenic effect may serve as a risk as well. So now let's look at sleep alertness disturbance and the maintenance of substance abuse. Let me begin with the opioids, which are well known for their both sleep disruptive effects and, of course, their very high abuse liability. And these are actually studies that I was involved in, a rat model of addiction to an opioid, in this case morphine, methadone, and a long-acting version of methadone. And let's focus here on the on the administration of morphine, 10 milligram per kilogram, and the effect of the morphine on sleep-wake cycle in rats made physically dependent on morphine. After the administration of morphine, there's a period of continuous wakefulness, and then slowly non-REM sleep begins to emerge, and then finally in the last hour, the appearance of REM sleep with wakefulness interrupting the REM sleep, and the rat wakes up out of REM sleep and takes another injection of morphine. This self-administration pattern, this 3-hour pattern, continued for up to 6 months. It continued throughout the light-dark cycle, 12 hours light, 12 hours dark, and the animal took 8 administrations every 24 hours with this 3-hour cycle of wake, then non-REM, and then REM sleep. In other words, the drug taking captured the distribution of wake and sleep across the 24-hour period, as well as the distribution of non-REM and REM sleep within each of the intervals. Now, the important point is the REM suppressing effect of the drug and the impact of discontinuation. Here in the dark bars are the minutes of REM sleep during the administration of morphine. In this case, it's 20 milligrams per kilogram. And then on day 1 through 12 of the discontinuation, this is the normal level of REM sleep in non-addicted rats, and you can clearly see a rebound in REM sleep in these physically dependent rats. So, what is the potential clinical significance of this REM deprivation effect? And why is this important? You see, among pain medication dependent patients, pain severity is related to insomnia severity index scores, and the patients initially report using the medication for pain, but then they begin to report that they're using it for other reasons, such as to get high or to get sleep. Now, here is the pain sensitivity in healthy volunteers. I use a finger withdrawal methodology in which healthy normals are given the opportunity, are tested for their sensitivity to a radiant heat stimulus, and these are finger withdrawal latencies after 8 hours of sleep. We test these people at 10 in the morning and then at 2 in the afternoon. And for example, you see that sleep deprivation here in the 2-hour bedtime condition enhances pain sensitivity. In other words, finger withdrawal is reduced. In a REM deprivation condition where these healthy normals are awakened every time they go into REM sleep, and we effectively deprived them of REM sleep. They had, on average, about 2 minutes of REM sleep. And compared to a critical comparison or control group, or condition, I should say, in which they're awakened as frequently with the approximate distribution across the night, except that the awakenings occur during non-REM sleep. And you can see that pain sensitivity, in other words, finger withdrawal latency, is reduced relative to the control condition and similar to 2 hours of bedtime the previous night. Now then, let's look at another drug group, the cannabinoids, which are known to have sleep effects and abuse liability, clear abuse liability. And these are sleep recordings done in heavy marijuana smokers. We're comparing sleep efficiency here in a control group or in these heavy marijuana smokers given a placebo THC cigarette or a 3.27% THC cigarette. And you can see that sleep efficiency is diminished after daytime placebo versus daytime THC, and the placebo condition differs from the controls as well as the active drug condition. The impact is occurring primarily due to minutes of wake and light sleep, stage 1 sleep, during the night. So in the placebo condition, it is elevated relative to the active THC group smoking condition. Now, interestingly, the percent of slow wave sleep on placebo is diminished, but it is also diminished on the THC active smoking condition. This is very much similar to what we showed with alcohol, a difference in slow wave sleep between healthy normals, and here you see the same difference between the control individuals and the heavy marijuana smokers. So at this point, I've presented studies that I've done in terms of the potential of sleep alertness disturbance maintaining a substance use disorder. And there certainly are numerous self-report data that support the hypothesis that sleep alertness disturbance plays a role in maintaining other substance use disorders. Now then, let's move to sleep alertness disturbance and its role in relapse to substance abuse. The first group of studies are in patients who have alcohol use disorder. These are data reported by Berro, and it refers to sleep recordings done after the acute discontinuation of alcohol, and then these individuals are followed for 3 months, and you can see that sleep onset is elevated in those who relapsed versus those who were able to abstain after 3 months. And this is REM sleep latency, again, the relapsers versus the abstainers, and a significant reduction in REM sleep latency. These studies were then continued for up to 3 years, really, and that relapse versus an abstaining difference continued for up to 3 years. Now, Berro has also shown that slow wave sleep deficiency is also predictive of relapse. REM disturbance was also reported by Gillen. This is REM latency. It was reduced in relapsers relative to abstainers. This is REM percent, and REM percent is elevated in relapsers relative to abstainers. And notice, these are patients with alcohol use disorder who do not have depression. And the point is, depression shows the same in patients with alcohol use disorder and depression, the same relapse versus abstinence differences in REM percent and as well REM latency, and the effect appears somewhat enhanced in the depressed versus the non-depressed patients. But the point being that this cannot be attributed to depression alone. Now, another substance use disorder which has been investigated relative to sleep predictors for relapse is cocaine dependence. This is data during an inpatient stay for 3 weeks versus outpatient discontinuation. And again, those who were able to maintain abstinence reflected by negative urines, and those who were able to maintain abstinence were those in whom slow wave sleep increased from inpatient to outpatient time, and as well slow wave sleep was also associated with the number of consecutive days of abstinence in this particular study. In this particular study, normalization of REM time over the inpatient to the outpatient period was predictive of negative urines, and also the consecutive days of abstinence. But note, with the absolute values, REM latency was still relatively low. This is early abstinence, 40 minutes, and this is late abstinence, 61 minutes. And as most everyone understands, a normal REM latency is 90 to 100 minutes. Now, early on in 2010, Brower and Perrin hypothesized, in former terms, we hypothesized that persons who are recovering from an addiction to any psychoactive substance and have a sleep disturbance are at an increased risk of relapse compared to those without a sleep disturbance. In other words, sleep disturbance is a universal risk for relapse in addiction to all psychoactive substances. Summarize. Disturbed sleep is associated with substance abuse, and that's true of all phases of the addiction cycle. I've emphasized the importance to distinguish therapy seeking from drug seeking, and to recognize that focus can shift. Now, it is yet critical to determine the extent to which sleep disturbance is predictive of relapse in other of the drugs of abuse, and then to further learn the extent to which treatment of sleep diminishes relapse probability. We don't have time to discuss the treatment effects in the studies that have been conducted, but in alcohol use disorder, various pharmacologic treatments for the sleep disturbance or behavioral treatments for the disturbance have had positive effects on the sleep disturbance, but they have not had any significant effects on the ability to abstain, at least at this point. So, finally, let me acknowledge my various collaborators throughout this series of research studies and the various grants which have supported these studies.
Hello everyone, it's my great pleasure to be here presenting to you today. The title of the current presentation is Effects of Sleep-Wake Manipulations on the Abuse-Related Behavioral Effects on the Drug of Abuse. The purpose of this presentation is to provide an overall scenario of how the sleep-wake cycle can interfere with drug of abuse. First of all, it's important to define psychoactive substances that are those characterized by acting in the central nervous system. Psychotropic drugs are those whose main clinical effect is to produce a change in the psychological state. Within these effects, there are substances that induce central reinforcing actions. In other words, these drugs can cause their repeated use lead to a formation of a habit and ultimately to dependence. The drug dependence promotes alteration large scale in the organism, affecting several systems as well as routine and behaviors. In parallel, sleep deprivation is well known to produce marked impacts, such as impairment of the immune defenses, cardiovascular outcomes, cognitive deficits, mental disorders, among others. And here we can see, for instance, how this produces a global effect on the body. By examining the relationship between sleep and neurochemical pathways, Nora-Volkow and colleagues reported reduced D2, D3 receptors availability in this triaton after sleep deprivation, indicating that impaired sleep patterns contribute to the low D2, D3 availability in brain regions. This result may be involved in the associated decreased wakefulness. As cocaine abusers have disrupted sleep patterns, in this article they investigated whether reduced sleep duration mediates the relationship between cocaine abuse and the low striatal D2, D3 receptors availability. Compared with controls, cocaine abusers had shorter sleep duration, went to bed later, and reported longer periods of sleep disturbances. In addition, cocaine abusers have reduced striatal D2, D3 receptors availability. The current findings have clinical implications suggesting that interventions to improve sleep patterns in cocaine abusers undergoing detoxification might be beneficial in improving their clinical outcomes. Chronic cocaine users often experience persistent reduction in total sleep time, and incubation of cocaine craving is partially mediated by progressive accumulation of calcium permeable AMPA receptors in the nuclear accumbens. After withdrawal from cocaine, animals with improved REM sleep exhibit reduced accumulation of CP-AMPA receptors in the nuclear accumbens, whereas increasing sleep fragmentation accelerates nuclear accumbens CP-AMPA accumulation. These results revealed a potential molecular substrate that can be engaged by sleep to regulate cocaine craving and relapse, and demonstrate sleep-based therapeutic opportunities for cocaine addiction. Our group has also demonstrated participation of neurochemicals, such as dopamine, related to sleep in drug-related protocols in animal models. The examples shown so far deal with psychotropic drugs, that is, they have a reinforcing effect. Thus, these substances can lead to an emergency of addiction, at which time there is a transition in the relationship between the individual and the substance consumed. The emergency of addiction is defined as highlighted in DSM-5 when this consumption of the drug begins to compromise the individual activities, including routine, interpersonal relationship, and performance in professional activities. Individual actions are mainly aimed to obtain the preferred substances. Those consumption is no longer due to its effect perceived as beneficial and become a way to avoid or minimize withdrawal symptoms generated by the drug. That is, therefore, a transition from positive to negative reinforcement. In the case of individuals seeking to stop using the substance on which they have become dependent, another concern is development of withdrawal symptoms. After the interruption of substance use, it's commonly reported that there is an increase in complaint of insomnia, worsening of anxiety, and mood disorders, in addition to general increase in irritability, aggression, and agitation. In view of what have been observed so far, it can be said that sleep is one of the factors most affected by substance use disorder. However, a current concept in recent years has gained ground, arguing that connection between drug use and aspect of sleep has a bidirectional nature. Thus, a question remains to be explored. Can sleep or elements directly linked to sleep modulate substance use disorder? Starting from the concept that sleep is an agent and not just the target of action in substance use disorder, there are multiple mechanisms and aspects that deserve investigations, offering valuable evidences that contribute to the understanding of the relationship between sleep and substance use. This presentation today aims to examine and discuss some of these aspects and mechanisms. We are going to highlight in the next couple of slides the importance of animal studies. These findings allow us to extrapolate clinical relevance from its own results, linking the pillars of basic research with the broad territory of clinical data. In fact, subsequent studies have also verified that many of these data in humans that are subjected spontaneously to sleep deprivation. Therefore, based on the translational potential of research in this field, it's possible to build an evidence bridging between clinical and basic data, generating a synergy that contributes to the expansion of both study fronts. To understand how sleep influences substance use, it's necessary first to address the methodology that can be used to guide this investigation. It's impossible, therefore, to talk about modulation in the sleep-wake cycle without talking about sleep deprivation protocols, the most consolidated way to assess the effect of sleep on the body. Sleep deprivation in animal models can be total, in which animals are totally sleep deprived for any phase of sleep during a certain period of time. Total sleep deprivation protocols nowadays use the gentle handling method, much more common, in which manipulations such as opening the cage, including new objects for exploration, and using brushes to keep animals on alert are preferred. Gentle handling, as its name suggests, is a less invasive form that causes a reduced stress load compared to methods such as the rotating disc shown on the left that was previously used considerably in many studies. In relation to paradoxical REM sleep deprivation, the platform method, in which animals are placed on the platform over water, is still widely used. Upon entering paradoxical sleep, muscle atony occurs and the animal ends up touching the water due to reduced size of the platform, waking up. The paradoxical sleep deprivation method is discussed since in many countries is less used nowadays. The drugs to be shown in this presentation include stimulants, cocaine and amphetamines, depressant drugs. Here we will talk about opioids and alcohol, and a wide variety of synthetic drugs, one of the main trends observed in the recent years around the world. Among these synthetic drugs, it's worth mentioning MDMA, a well-explored substance that has a long history of use in humans. The list is not too long, but it does address substances that are in great evidence in the scientific literature that focus on the relationship between sleep and substance use disorder. Psychostimulants prominently include cocaine and amphetamines, drugs that promote the acceleration of mental processes. In mechanism of action, the central nervous system depends mainly on dopaminergic neurons, since they are drugs that inhibit reuptake and stimulate the release of dopamine. They are drugs of widespread use worldwide, with high potential of habit formation and establishment of addiction. Due to their stimulant properties, they are extremely popular drugs among young people. The application of sleep deprivation methods in mice and rats has already shown the importance of sleep in the evolution of the characteristics of the substance use disorder. In the study conducted by Dr. Berro, shown here, it was observed that a period of sleep deprivation was able to confirm the behavioral changes already observed in mice treated with cocaine. The presence of hyperlocomotion in relation to animals that had not been subjected to sleep deprivation was observed. This intensification or potentiation of the behavioral response characterized what we call sensitization to the effect of drugs. In this other study of the same group, the difficulty in extinction, interruption of cocaine use in mice was addressed. With this protocol, it was possible to observe that animals deprived of sleep have greater difficulties in the extinction of locomotion induced by cocaine, while the restatement of the use of the drug was facilitated in animals that have been sleep deprived. In rats, similar protocols result in different behavioral changes. We observed an increase in stereotyped behavior, which includes incomplete growing, intermittent links and bites, and false bites after treatment with cocaine associated with sleep deprivation. In this study shown here, rats were subjected to sleep restriction, a technique that allows the animal to sleep only for a predefined interval of time. Therefore, it differs from sleep deprivation, in which the animal is not given the opportunity to sleep during the protocol. Shane and colleagues restricted the animals from sleep in its light, inactive phase. An unusual effect that we reported 20 years ago was the increase in the number of spontaneous erections and ejaculations observed in rats treated with different doses of cocaine. It can be noted here that sleep-deprived rats consistently display an increase of these spontaneous behaviors events when compared to the control group. Opioids are a large class of depressant substances, that is, slowing mental processes, derived from morphine, among the many molecules presenting here today, such as fentanyl, methadone, and heroin. They stand up for recreational use. Its depressant action occurs mainly due to its effect on the mu receptors and they make up a class that, like psychostimulants, also has significant reinforcing properties. Drugs are widely consumed both in North America and Europe for purposes that include medication, self-medication, and recreational use. At the present time, it's impossible to discuss the use of opioids without going through the situation that happened in the United States. CDC data showed an alarming increase in the number of deaths from opioid use in recent years. It should be noted that the use of opioids has often been associated with the use of cocaine, and that a large number of deaths are due to the combination of these substances. Since opioids are a class of drugs widely used to treat pain, it's necessary to address the complex association between sleep and pain, which has been widely reported in the literature. As shown in the table, an experiment conducted with arthritic rats displayed that sleep deprivation promoted a decline in the animal's pain threshold when compared to animals kept in their cages. It is also important to verify the relationship between sleep loss and morphine on wound healing that have been focus of several papers. Going deeper about opioids, the result shown in this article is a reduction of binding potential at opioid receptors in the limbic system of a rat, which is a fundamental component of the reward system. In parallel, these animals also showed greater locomotion activity after 3 days of sleep deprivation, as well as marked increase of the exploratory activity, suggesting that the opioidergic system may have a fundamental role in behavioral regulation, as what occurred in the sleep deprivation scenario. Interestingly, this study showed that instead of enhancing the effects of the rewarding system induced by morphine, sleep deprivation promoted a sharp drop in the score of the conditioned place preference tests, indicating deficits in memory consolidation reward for those animals. These curious findings are corroborated by a study in which paradoxical sleep deprivation decreased locomotor activity due to sensitization by treatment with morphine in mice. Thus, is a clear evidence that is a great variety in the ways in which drug of abuse are related to sleep deprivation, sometimes having their effects enhanced by this sleep deprivation, sometimes mitigated by it. Many questions about the mechanisms that regulate this interaction still remain to be elucidated. Alcohol or ethanol is a legal drug widely used with effects that include the promotion of euphoria in lower dose and depressant effect in higher dose, with slowing down of cognitive and mental processes. The consumption of alcohol around the world is widespread and extremely prevalent in Europe and in the Americas. As already shown here, its indiscriminate use can lead to a series of health problems and social issues. The relationship between alcohol use and sleep has also been well explored previously. Paradoxical sleep deprivation can lead to increased alcohol consumption, as is extremely evident in this study. It is interesting to note that administration of a noradrenergic antagonist, taucipran, promoted a reduction in alcohol consumption after the beginning of the sleep deprivation, indicating a role of the noradrenergic system in this context. Moving on to the clinical implications of alcohol use, Young populations deserve special attention regarding the consumption of this substance. Practices such as binge drinking are particularly prevalent in this population, and given the neuronal formation processes still present in young individuals, alcohol consumption can have devastating consequences. Added to this marked presence of later hours, often also associated with the social life of these young people, in which leads to impaired sleep in these individuals. These two studies discuss these effects. The combination of alcohol use and sleep deprivation increased the potential evoked in the cortex of young adults, who also showed a decrease in performance in cognitive tasks. In relation to the hours practiced, it was shown in the study in 17 that young people has greater neuronal activation in the face of situations that involve reward in the eveningness, in addition to greater probability of developing alcohol dependence in the period of 2 years. Now we are going to show some data on synthetic psychoactive drugs, a class that has been growing and becoming clinically important in recent years. As previously mentioned, MDMA is a drug that can be listed in this class, but many other molecules have been characterized here. These make up the so-called new psychoactive substances, that is, synthetic drugs analogous to known psychotropic substances, such as amphetamines and opioids, and which are intended to replace illegal or difficult to access drugs. Often, these synthetic psychoactive drugs can have effects similar to psychostimulants. In relation to MDMA, it has been reported that sleep deprivation impairs the cognitive performance in some users. And it's important to mention also that the time to give a response of these individuals increased drastically, although it has been correspondent to reduction in the number of corrected answers. Here we have an example of how sleep should be considered in the studies with new psychoactive substances. MCPP is a relatively new drug on the market with stimulating properties. In this study, our group identified that there is a marked reduction in the exploratory behavior of mice in the open field, indicating an increase of anxiety-like behaviors. Sleep deprivation for 48 hours also promoted the maintenance of higher level of the substance in the plasma compared to animal of the control group. So, what can we propose as future perspective in this subject? Steps that still need to be taken in the future would be precisely the focus on investigating the influence of manipulation on sleep on the theoretical framework already established in relation to protocols with self-administration drug in non-human primates. These steps would be useful to understand whether sleep influences the pattern of self-administration, the extinction and restatement of the substance use, and would also certainly contribute to form a bridge between these findings already documented in rodents and the perspective and prediction for humans. Despite the number of evidences that have been emerging and helping to break the relationship between sleep and substance use disorder, they are not enough for us to face the greatest challenge and one of the most difficult questions to answer in the study of the psychopharmacology field: how to treat addiction. Treatment options for addiction caused by psychotropic substances have not yet been able to reverse the high incidence of relapse to drug use and the search for the mechanisms that regulate the individual's search for psychotropic substances and their susceptibility to relapse continues. In this sense, sleep can offer promising answers. We can conclude that sleep as an agent in the substance use disorder influences the individual's craving for the drug of choice, modulates behavioral effects, receives influence, and is also influenced by a magnitude of different biological systems, and therefore deserves the conduction of further studies in the future that contribute to the clarification of the neurobiology of drug use. Possible steps towards that future should include classes of clinically important drugs such as benzodiazepines and cannabinoids. And finally, as my take-home message, I would like to say that sleep should be an additional and very relevant step in the substance use disorder research, and we should continue for further studies and research on this topic. Here I would like to conclude my presentation and acknowledge many scientists that have contributed to the data showed here, and I would like to thank Dr. Berro for this invitation and all of you for your attention.
Hello, my name is Stephanie Borgland. I'm a professor at the University of Calgary. The title of my talk is Orexin Mechanisms Regulating Sleep and Reward. Orexin neurons were discovered in the late 1990s. Luis de la Chia from the Sutcliffe Laboratory isolated a full-length cDNA corresponding to the precursor preprotein containing two similar putative peptides. The mRNA was exclusively located in the dorsolateral hypothalamus. The novel gene was termed hypocretin due to its hypothalamic expression pattern and the similarity of the peptide sequences to members of the incretin family. A second paper was published a month later by the Yanagisawa lab and identified the same gene using a different approach to identify orphan GPCRs. They identified two peptides, orexin A and orexin B, derived from the Greek word orexis, meaning appetite, as they found that central administration of these peptides increased feeding. Orexin neurons are required for the maintenance of wakefulness states. The graph on the left shows discharge of lateral hypothalamic orexin neurons across sleep-wake states recorded from a rat. It was post hoc labeled to identify it as an orexin neuron. In the 10-second trace above, the unit in red fired action potentials during active wakefulness, and this increase in phasic firing was associated with increases in muscle tone reported in the EMG trace. This shows that orexin neuronal firing is critical for maintaining arousal with muscle tone, which is lost in patients with narcolepsy and cataplexy. 2 years later, using optogenetics for the first time in vivo, when a light-activated ion channel was expressed in orexin neurons to control the firing, it was found that with optical stimulation of orexin neurons, you could transition the mouse from slow wave sleep, or REM sleep, to wakefulness. These experiments later led to the development and FDA approval of a drug that inhibits the orexin or hypocretin receptors and provides an effective treatment for insomnia. This drug, called suvorexant, which is marketed under the name Belsomra, has equal potency for orexin 1 and orexin 2 receptors. Indeed, orexin application to VTA slices increases firing of VTA dopamine neurons. Orexin also increases NMDA currents through activation of orexin 1 receptors expressed on VTA dopamine neurons. The activation of orexin 1 receptors on VTA dopamine neurons leads to a PKC-dependent trafficking of NMDA receptors to the membrane. This trafficking of NMDA receptors leads to a later trafficking of AMPA receptors to the synaptic membrane, suggesting that orexin signaling on VTA dopamine neurons increases synaptic strength. So why is potentiation of NMDA receptors and synaptic plasticity in the VTA important? The VTA dopamine system is involved in motivated or goal-directed behaviors for both the natural phenomena like eating, social interaction, and mating, but also it's been shown to be critically involved in the development of pathological states associated with things like drug addiction. Dopamine neurons fire spontaneously. However, with presentation of motivationally relevant stimuli and/or increased activation of excitatory amino acid receptors, such as NMDA receptors, this leads from a shift from tonic firing, represented in the traces above, to phasic firing, represented in the recordings below. This phasic firing ultimately leads to increased dopamine concentration in target regions of the VTA, like the nucleus accumbens, and results in increased behavioral activation and motivated behavior. And this is important because addictive drugs can co-opt synaptic plasticity mechanisms in brain regions involved in the processing of reward and reinforcement. For example, 24 hours after a single administration of multiple addictive drugs, you observe an increase in the strength of excitatory synapses, as measured by the increase in the AMPA to NMDA ratio. This measure looks for a change in the relative contribution of AMPA receptors and NMDA receptors to signaling in the postsynaptic neuron, with an increase in the ratio likely being mediated by an increase in AMPA receptor expression at the membrane, reflecting the induction of plasticity mechanisms such as long-term potentiation. Potentiation of excitatory synapses onto dopamine neurons in the VTA increases dopamine release to VTA targets that in turn triggers downstream changes in reward circuitry that may be associated and may account for the persistent drug-seeking behavior. Importantly, this plasticity in the VTA is associated with the learning of context paired with rewarding stimuli. For example, in this condition-place preference paradigm that used an apparatus with two distinct compartments, one can pair a reward like administration of morphine or cocaine with a particular context. During training, animals are given morphine in one of the compartments over repeated days. During the test, animals can freely explore each compartment, and the preference for a particular compartment is recorded. When NMDA or AMPA blockers are administered within the VTA, there is a reduction in the preference score, suggesting that activation of AMPA or NMDA receptors in the VTA is necessary for pairing contextual cues with rewards. A landmark study by Glenda Harris from Gary Aston Jones's lab showed that orexin neurons are activated, measured here with CFOS, during morphine or cocaine conditioning. Furthermore, mice given an orexin receptor 1 antagonist in the VTA or in mice that are lacking the orexin peptide do not show a preference for the context associated with drug experience. Further studies showed that orexin activation of orexin 1 receptors in the VTA are important for conditioning the association of context with psychoactive drugs like cocaine or morphine. Consistent with this, Orexin signaling is important for plasticity in the VTA associated with cocaine or morphine administration, as the orexin 1 receptor antagonist blocks formation of this plasticity, represented by the AMPA to NMDA ratio. Orexin signaling also underlies effort-based behavior. In a paradigm called a progressive ratio task, whereby rodents learn to lever press for a reward such as food or cocaine, the animals must lever press progressively more times to receive the reinforcer. So initially, they may get a reward for every time they press the lever, such as in a fixed ratio 1 reinforcement schedule. However, they will be required to press more and more times to get the reinforcer. The point at which the animal achieves the final ratio, so the maximum number of lever presses the rodent is willing to make to get a reward, is called the break point. Here, we show you that the orexin 1 receptor antagonist, SB334867, can inhibit the break point for cocaine in blue and high-fat food in red, but not regular food in green, with similar consistency as their home cage food. You'll notice from the cumulative pressing plots that when the effort ratio is easy, there's no difference in performance between the vehicle or antagonist-treated rats. However, when a higher effort ratio is required, you'll see the effect of the antagonist. This suggests that orexin signaling may be required for motivation to obtain highly salient rewards. On the right, this is reflected in orexin-induced NMDA receptor plasticity at VTA dopamine synapses, where by exposure to high-fat chocolate pellets or cocaine invokes a greater effect of orexin on NMDA receptors compared to regular food or those engaging the task at low effort, such as in the fixed ratio 1 schedule. So taken together, this data represents that orexin signaling may be required for motivation or effort for highly salient reinforcers, and this is reflected in plasticity at VTA dopamine synapses. So one theory has come up that orexin neurons may help transform motivational action into adaptive behavior. Sleep-wake activity is homeostatically controlled, with sleep pressure, which is represented by the black solid line. Sleep pressure increases the longer the animal is awake and subsides gradually over time asleep until sufficiently reduced to allow for awakening. Wakefulness is driven by a circadian signal represented by the dashed gray line. This circadian rhythm activates orexin and other arousal systems. Orexin neuron activity, represented by the red line, also has a circadian pattern, but also phasic bursts during waking as a function of motivational state and adaptive behavior. Orexin excites wake-active, for example, locus coeruleus and dorsal raphe, and inhibits sleep-active brain regions, for example, the medullary REM muscle atonia circuit. So discharge of orexin neurons during wakefulness helps counteract sleep pressure and decrease the probability of sleep initiation, especially during emotionally arousing situations. To add to this, orexin activation facilitates reward seeking, but only when the reward has significant motivational value or when the animal is in a motivated state, such as hunger or stressed. Thus, the orexin system is recruited during motivational action and triggered by internal or homeostatic or external motivationally relevant, such as escaping a stressor or a sexual opportunity, signals. So signals of threat or opportunity. Thereby, orexin in its different neural projections coordinate adaptive responses supporting behaviors that would have a cost benefit for the animal. However, one thing that is really interesting and not often considered is that 95% of orexin neurons are colocalized with the neuropeptide dynorphin. While orexin interacts with orexin 1 or orexin 2 receptors and typically induces excitatory responses, dynorphin interacts with kappa opioid receptors, leading to inhibitory responses, typically leading to hyperpolarization of the cell. While I showed you earlier that orexin can increase VTA dopamine neuronal firing, dynorphin, in fact, inhibits dopamine neuronal firing. Not only are dynorphin and orexin co-localized, they appear to be packaged in the same dense core vesicles, and therefore it's assumed that orexin and dynorphin would be released together. So John Mushams and colleagues tested the idea that dynorphin signaling may play a role in the drug-reinforcing effects of orexin. They showed that inhibition of the orexin 1 receptor in the VTA increases reward thresholds for electrical self-stimulation, decreases impulsive responding on a 5-choice serial reaction time task, and decreases cocaine self-administration. However, all of these effects are blocked by pretreatment with a kappa opioid receptor antagonist, suggesting that orexin in the VTA can negate the aversive effects of dynorphin. They propose that orexin may act together with excitatory glutamatergic inputs to overcome the inhibitory effect of dynorphin and GABAergic transmission onto dopamine neurons. This is an example of how application of the orexin 1 receptor antagonist SB334867, or also called SB here, inhibited cocaine infusions, whereas norbni, the kappa opioid receptor antagonist, had no effect. When both antagonists were applied together, the suppression of cocaine seeking by the orexin antagonist was reversed. This suggests that dynorphin signaling can oppose orexin signaling on cocaine seeking. So VTA dopamine neurons have a variety of projection targets, and through each of these targets have differing functions. For example, dopamine projections to the nucleus accumbens are sensitive to appetitive, like cocaine, and aversive, like formalin, stimuli, and are typically involved in behavioral activation, whereas dopamine projections to the medial prefrontal cortex play a role in working memory. Thus, orexin and dynorphin may modulate different dopamine neurons with different projection targets in a different manner. So we tested this idea in my lab. Corey Bamel, a graduate student at the time, retrogradely labeled VTA dopamine neurons from different brain regions, including the lateral or medial nucleus accumbens shell, as well as the basolateral amygdala. He recorded responses of these dopamine neurons with known projection targets to exogenous application of either orexin or dynorphin. Our hypothesis was that orexin and dynorphin modulate different circuits originating in the VTA differently. He found that orexin application to the VTA dopamine neurons that project to the lateral shell of the nucleus accumbens increased firing in about 80% of the neurons. This effect was independent of synaptic transmission, as suggesting that activation of orexin receptors on VTA dopamine neurons induces intrinsic changes to promote excitability. When he applied dynorphin to dopamine neurons that project to the nucleus accumbens lateral shell, he found that it induced a suppression in only about 35% of the neurons. These data suggest that while orexin and dynorphin have opposing effects on firing in this projection, this effect is dominated by orexin as far as the proportion of cells that are modulated are concerned. Orexin did not alter firing in the dopamine neurons that project to the basolateral amygdala. These neurons were insensitive to the activating effects of orexin. However, dynorphin suppressed the firing rate of basolateral amygdala projecting dopamine neurons in about 60% of these neurons, and the average is represented by the gray traces, whereas the responders are represented by the orange-colored traces. Orexin increases firing in most of the lateral accumbens shell and medial accumbens shell projecting dopamine neurons, but not the basolateral amygdala projecting dopamine neurons. Dynorphin inhibits a small population of lateral accumbens shell projecting dopamine neurons, but most medial accumbens shell projecting and basolateral amygdala projecting dopamine neurons. Combined, orexin and dynorphin signaling in the VTA may coordinate dopaminergic output to bias activity towards the lateral accumbens shell, which may serve to engage the animals in effort. At the same time, orexin and dynorphin in the VTA dampens activity to the basolateral amygdala, which subserves different tasks, such as acquisition of aversive and appetitive conditioned responses. Given that orexin and dynorphin are co-released, and orexin and dynorphin can differentially modulate different neuronal projections from the VTA, it's important to know what the net effect of endogenous activation of the lateral hypothalamic orexin input to the VTA. To do this, we employed optogenetic strategies, where we transfected orexin neurons with the light-activated ion channel rhodopsin, or a control reporter. This allowed us to use blue light to control the firing rate of orexin neurons and to drive orexin and dynorphin release into the VTA. Exogenous application of orexin in the VTA increases dopamine release, where systemic orexin 1 receptor antagonists inhibit cocaine-invoked dopamine. Conversely, exogenously applied dynorphin decreases dopamine in the nucleus accumbens. Therefore, it's important to determine what the net effect of stimulation of these inputs to the VTAs. We first tested if optical stimulation of intra-VTA lateral hypothalamic orexin dynorphin inputs alone can evoke dopamine in the nucleus accumbens core using fast scan cyclic voltammetry, an electrochemical detection method for dopamine concentration. Optical stimulation of these fibers in the VTA did not significantly alter nucleus accumbens dopamine concentration, measured as area under the curve on the right or peak dopamine on the left, in either M-Cherry controls or channel rhodopsin group. However, optogenetic stimulation of lateral hypothalamic orexin dynorphin inputs in the VTA significantly potentiated electrically evoked dopamine neurotransmission in channel rhodopsin, but not M-Cherry mice. This suggests that orexin and dynorphin signaling in the VTA requires associated phasic activation to potentiate dopamine responses in the nucleus accumbens. We next tested if orexin 1 receptor signaling was involved in potentiation of electrically evoked dopamine. Mice were treated with the orexin receptor antagonist, SB, prior to evoking dopamine with electrical, represented by the gray lines, or electrical plus optical stimulation of dopamine neurons, represented by the green lines. Inhibition of orexin signaling completely inhibited the potentiation of nucleus accumbens dopamine by stimulation of the lateral hypothalamic orexin dynorphin inputs to the VTA. These data indicate that the potentiation of dopamine release by stimulation of these neurons is driven by orexin rather than dynorphin. We next asked if optical stimulation of lateral hypothalamic orexin dynorphin inputs to the VTA is rewarding. We placed mice in an apparatus with two compartments. Mice received optical stimulation only in one compartment of the apparatus. These pairings of optical stimulation of lateral hypothalamic orexin dynorphin in the VTA with the compartment occurred over 3 consecutive daily hour-long sessions. The day after, mice were placed again in the apparatus in the absence of stimulation. Time spent in each compartment was measured. While M-Cherry control mice, in orange, did not develop a significant preference for either compartment of the apparatus over the 3 stimulation sessions of real-time place preference. However, the channel rhodopsin mice in blue demonstrated a significant preference for the compartment paired with intra-VTA lateral hypothalamic orexin-dynorphin stimulation over the 3 stimulation days. To determine if intra-VTA photostimulation of the orexin-dynorphin inputs can influence associative learning mechanisms, we next examined whether M-cherry or channel rhodopsin mice demonstrated a preference for either compartment in the absence of optical stimulation in a subsequent session. While the M-cherry mice did not show a significant preference for either compartment, the channel rhodopsin mice spent significantly more time in the compartment previously paired with stimulation. These data suggest that stimulation of lateral hypothalamic orexin-dynorphin terminals in the VTA is rewarding, and that mice continue to associate the preferred side with stimulation even in the absence of that stimulation. We next examine the role of orexin 1 receptor signaling using the antagonist SB334867 in preference for optical stimulation of the orexin-dynorphin inputs in the VTA. The vehicle group developed a significant preference for the compartment paired with lateral hypothalamic orexin-dynorphin stimulation in the VTA over the 3 stimulation days, whereas the SB334867 group did not develop a significant preference for either compartment over the stimulation sessions. Furthermore, mice given the antagonist showed no significant preference for either compartment in the post-stimulation test session. So taken together, inhibition of orexin 1 receptor signaling prevented both the development of preference for the lateral hypothalamic orexin-dynorphin optical stimulation in the VTA, as well as its associated memory. Given that inhibition of orexin signaling can block condition-placed preference and inhibit relapse to opioid, cocaine, or alcohol in rodent models, can suvorexant, the FDA-approved dual orexin receptor antagonist, be used as an anti-addiction therapy? In animal models, suvorexant decreased cocaine condition-placed preference, as indicated here in the upper graph in the condition-placed preference score, whereas there's a small reduction with 30 milligrams per kilogram suvorexin application in preference to cocaine. Similarly, administration of 30 milligrams per kilogram suvorexin decreased cocaine infusions in a self-administration paradigm. This is represented in the lower graph here. Although there was a trend for a reduction in active lever presses, there was no significant effect. So it seems like suvorexin in preclinical models may have some, if not mild, efficacy at reducing cocaine preference and cocaine self-administration. Currently, there's a phase 2 trial for suvorexin in the treatment of insomnia in clients with comorbid alcohol use disorder in Australia. Therefore, hopefully within the next couple of years, we will have data from these clinical trials to see if these antagonists will be useful in treatment of substance use disorders. So to summarize, orexin neurons are involved in maintaining wakefulness, and the lack of orexin peptides, orexin neurons, or mutations to the orexin receptors leads to narcolepsy and cataplexy. Orexin neurons exhibit different effects depending on their projection target. So, for example, orexin projections to the locus coeruleus are involved in arousal, threat memory association, whereas orexin neurons that project to the VTA are involved in reward seeking. So orexin action in the VTA promotes conditioned associations of motivationally relevant information. Orexin is co-expressed and presumably co-released with dynorphin, so these two peptides typically have opposing action. The lateral hypothalamic orexin and dynorphin modulation of VTA dopamine neurons is projection specific, whereas it appears that orexin modulation of dopamine neurons that project to the nucleus accumbens dominates, whereas orexin and dynorphin modulation of dopamine neurons that projects to the BLA, the effects of dynorphin appear to dominate. So stimulation of these lateral hypothalamic orexin and dynorphin inputs to the VTA increases nucleus accumbens dopamine. And finally, stimulation of the lateral hypothalamic orexin dynorphin inputs to the VTA increases place preference and acquisition of associations. So, in summary, orexin may be integrating the animal's internal state, its arousal and metabolic drive state, with other physiological factors such as circadian or environmental stimuli into goal-directed behaviors or motivation or effort to obtain those cost-benefit adaptations. So in summary, I'd like to thank the members of my group that participated in the project that I demonstrated to you today. This work was from Corey Bamel's PhD thesis, and Jennifer Thompson also participated in this. And current lab members that are involved in this project include Catherine Thomas, Ida Mohammed Khani, Madiha Rana, and Min Chow. And thank you for your attention.